John Michael Yingling, we're going to go over it's a technique paper we submitted. This is just a PowerPoint showing the technique for percutaneously fixing the posterior column with this curved intramedullary implant. We feel like there's a role for this in acetabulum fractures, as we alluded to. Here's a plastic model showing the trajectory from the iliac tubercle through the gluteal pillar down into the ischial tuberosity. And here's an AP and an iliac oblique fluoroscopic view showing what that looks like, on X-ray. In the technique paper, we used a couple cases. This was one of them. It was an 80-year-old male who had an acute acetabulum fracture on the right around a revision-style hemiarthroplasty. Also had a pelvic ring injury at different stages of healing, along with some cement augmentation into sacrum and spine. Here's some select CT cuts showing this protrusio, sort of associated both column acetabulum fracture with no real connection. Imaging is important for using this technique. The iliac oblique view allows you to see the anterior and posterior margins of the posterior column, demonstrated by our lovely radiology tech here, and also the sawbones. Here's what it looks like on fluoroscopy. This is just at the step where we inserted our reamer. The other view, when you're starting, would be the obturator oblique outlet. It allows you to see the medial and lateral margins of your gluteal pillar, as demonstrated here on fluoroscopy. This is a little bit less of an outlet just because we had to have this patient's hip flexed for the acetabulum portion, or the intrapelvic portion. An AP image is important for determining the medial and lateral corridor around the periacetabular region, so demonstrated here and here. Superficial landmarks, you identify your ASIS and a few, 3 to 4 finger breadths posteriorly is where you'll find your iliac tubercle, which is the most cranial extent of your gluteal pillar and gives you access to the posterior column. Originally, we would make larger incisions just so we could ensure that we weren't going through the abdominal muscles, but you incise lateral to that where it inserts on the crest, so you can prevent from, insulting the muscle bellies themselves. Here's an example of the obturator oblique outlet where you can see you're in between the inner and outer table of that gluteal pillar after your entry guide wire and then entry reamer. And then here, getting the iliac oblique, ensuring that you're at least heading towards in between. Here's your posterior cortex of your posterior column, and then behind the acetabulum. This is the AP view now that your steerable guide wire is being inserted a little bit further caudal. And again, ensuring that you're in between your median and lateral margins here, and then following it again on your iliac oblique, ensuring that you're in the retroacetabular space and within the posterior column. Here's an AP view demonstrating after you had reamed and exchanged your wire and then placed the implant. And then the iliac oblique view showing the same. Here's the final fluoroscopic images showing what we did at the end of the case, showing everything. There's the inlet outlet views. There's a video of him immediately post-op, just showing that he was able to get up after several weeks of being completely immobile. He takes a few steps, and then at 6 months, he's completely healed. He still ambulates with a walker, but at least he's independent here. So just... Another important thing I wanted to mention was as you're using the guide wire, steering past the pelvic brim, oftentimes that's where the fracture is and it can exit there. You can use percutaneously or within that same incision, sliding under the iliacus muscle using a malleable or a cob or some other instrument as a blocking instrument to prevent it from passing there. Serendipitously, this person had a quadrilateral surface plate already that acted a bit as a blocker there.